Let's see here. Yeah, Dr. Guerin said she didn't know how many of you guys. I probably need to.
Looks like she just logged on.
Dr. Guerin did?
Yeah, it looks like it.
I'm here. I made it.
Perfect timing. We were just kind of talking about their backgrounds.
Okay.
Right, so I know what kind of audience I have.
Okay. I don't usually run my video. The photo I have up, they photoshopped it, so it got all my wrinkles gone. So I like it better. So why don't did you introduce yourself, Trina? And I will I'll mute myself and let you carry away. Okay.
Okay. Can you guys see me, or is it just my screen?
No, I can see you.
We can see
okay. You. Okay. Good to know, because the last couple times I did this, you couldn't see me. So I made sure, because I work at night right now, so I woke up just a couple hours ago.
Oh, same here.
Yeah. So you get yourself presentable, and I have to go to work tonight after I'm done with this.
Oh,
no. Well, it's fine. So I'll tell you a little bit about my background. I've been at Hoag Hospital in Newport Beach for 15 years. I was actually born in that hospital and have worked there my entire nursing career. I worked in the ER first for a year, and then I went into labor and delivery for about 5 years. I moved over to our Orthopedic Institute, and that's where I started my leadership career as a charge nurse first over there after I was a staff nurse, and then I became a manager. Over there in our Orthopedic Institute, I managed our pre-op, PACU, pre-admission screening, and our nurse navigators. So I had about 54 direct reports. During that time, did all their eval scheduling, all of their conflict issues, and plus got 25 to 30 patients to surgery every day on time. And so that was a lot of work, and I worked about 50 to 60 hours a week while doing that. And that leads me to why I am now a charge nurse again. My son was having some issues with bullying in school, and I felt like I needed to be at home more, and chose to return to the bedside somewhat. So I returned to labor and delivery for about a year at the bedside as a staff nurse, and then quickly became a charge nurse again, because I guess I need to be in charge of everything. And so that's what I do right now. The labor and delivery unit that I work in again now is, we do about 600 deliveries a month, and we deliver and we deal with about 40 doctors. It's very busy. There's 150 employees between the day shift and the night shift. And I am one of 3 charge nurses on the night shift. And being that we are so busy, we deal with a lot of conflict. And I find that the department I'm in now, I deal with more conflict than when I was manager. So that leads us into our topic. So I always this is a slide deck that Dr. Guerin gave me 3 years ago from our Porter O'Grady book, and I'm not sure if that's the same book you're still using, but I loved that book and I still have it. And I think that it really clearly and kind of bottom lines things so that you can understand really from the root of where things come from. So this slide I especially like, and that it talks about that conflict's negative and people don't like it, they avoid it, and there's nothing worse than a leader that avoids conflict, I think. And it's something that we need to use, and we need to use to our advantage, especially if we're in a leadership role. So this slide deck talks mostly, and I'm going to talk mostly about how to utilize conflict to make sure that you're doing the best things for your patients, number one, and then also for your staff and for your facility.
What's the name of the book that you said it was in?
It's called Quantum Leadership.
Oh, okay.
Yeah, I don't know. I think it was kind of older. Maybe Dr. Guerin uses a newer book now.
Well, yeah, they do have newer versions, but it's a recommended, I believe.
Oh, okay.
So I would bet most people don't buy it. It is a good book, but because I require a couple, I make that one recommended.
Oh, you know what? I think we did do that before. And you know what's funny is I'm one of those people that buys every one of the books, and then I keep them. And because I still feel like I go back to them a lot. But Porter O'Grady, it's a book I would recommend you getting, because the way they talk about all of these issues, the way they explain it resonates with me really well. Maybe it's my communication style, I don't know, but I like it. I like the other giant book that you had. I can't remember what that one was called, but that one was really good too. I never felt like any of the reading you assigned us was wasteful in any way. So
thank you.
anyways, conflict.
Hooray. Wait. I have to say hooray.
Oh,
I'm sure not everybody feels that way.
no, I think you, if you're doing this job and you go to school and you're doing the job at the same time, I mean, that gives you quite a perspective. So anyways, we'll talk about conflict's normal, and it's present if you think about in your everyday life. You have a spouse, or you have children, or other family members, siblings, whatever. You're dealing with conflict all the time. You've been dealing with it since you were young, and it's something, we are social animals, and so it's something that is just naturally present. And then that brings you to the next topic. Embracing conflict is easier said than done. And the main causes of problems that can arise with conflict: fear, avoidance, ignorance. Fear and anger, and fear and hurt are what make anger. That's something that's always made me think, somebody's fearful and they're angry, they're fearful, they're hurt, they're offended, and then they get angry and they blow up. And I deal with the unit I work in right now is too small for how many patients we put through it. And so there's often fighting about beds and staff, and who can go to the OR first, and whose patient is more critical, and should we get a second anesthesiologist? Do we need to run 2 cases at the same time? There's always all of that. There's a lot of conflict with that.
Trina, I wanted to add on this one, and I don't think I've said it to this group, but one year I had somebody from the counseling department, and so she wasn't a nurse, so we were describing, and I think I described like one of the physicians that would be like just scream and yell, and he'd be so angry at us. And so she said something that I've never forgotten, and I wish I'd known back in those days of yelling physicians. And she said, when I see someone like that, I sit there and think, I wonder what he's afraid of.
Yeah.
And I had never at that, again, when you're being yelled at, like you're kind of feeling that fear and avoidance,
Yeah.
but I didn't turn it around and think he's afraid of something. And that's why he's behaving like that. And to me, if you reframe it, it really helps you deal with that.
It absolutely does, to understand. It's very hard to control your emotions during that, when somebody's being that awful, for you to sit there and say, hold on, what is it that this person's wanting or needing or asking of me right now? And how can I, 1, figure that out, and 2, diffuse this right now? Because with me, I mean, I work with a lot of young nurses, and our normal staffing is 19 at night, and I've got 19 faces looking at me like, how are you going to protect us from this? And so that's something that you need to figure out. How can I diffuse this quickly and resolve it, and make sure we're doing the right thing for our patients? Not just making this person stop yelling, because usually they're being ridiculous, but also making sure we get a good resolution. And the slide deck continues to talk about that in a little bit. So right here, this yellow spot's yellow for a good reason, and it says 90% of leadership is addressing human behavior issues that have some form of conflict at their base. When I first became a manager, and I would be at my desk, and I'd be wanting to do my audits and my evals and my staffing and watch my budget, and that was what I thought was my work. Okay. Well, maybe a year or 2 after I became a manager, I realized that all these people coming to my office and asking me for things, or telling me their problems, or what they think we need to fix in our units, or things like that, that was really my work, not what I had on my computer. And so dealing with these behavior issues is probably a number 1 job as a leader, especially in healthcare, because there's just so much conflict. And you have to, whenever emotional intelligence is such a hot topic right now in leadership. And I think that the best leaders have a high level of emotional intelligence. And I think that even though there's a lot of it that comes naturally, I think there's a lot that people can learn, even if it feels uncomfortable to you. If you can do as Dr. Guerin was saying, figure out what somebody's afraid of, and figure out where that person's coming from, and what did they deal with in their day that day that's gotten them to this point. Okay, sometimes I'll get a physician who's super angry, and I'll realize, oh yeah, I could see why that would make you angry. Something maybe one of my nurses has done, or something that the nurse communicated in probably not the best way she could have, because I have a lot of young nurses, or something that they felt like they said in front of a patient that made them look bad. And that's something often that I'll deal with also. And so how did we get to this point? And then here it talks about sources of conflict. So we have the, with physicians, I think there's a lot of ego and identity going on, and it's funny. It's hard for our physicians right now who have been at the bedside for maybe 30 years, because they still sometimes can't get into the in line where they realize that they're not king anymore, and they don't get to call the shots, and they have to work with the team, and they have to do what's best for everybody. And a lot of them do it kicking and screaming. And I have one in particular that I fight with a lot, and that's hard. And him and I have an understanding now, but it's still hard. And then you talk about the environmental sources, which we're seeing in our political environment right now, which is so charged and so scary, and a lot of change going on as a country right now, where you're looking at all these environmental sources and different classes, socioeconomic statuses, races, religions, nationality, culture, all of those things coming to a big head right now, and all this conflict, and hopefully we come out the other side better. So I love this line where it says that trying to create an environment where there's no conflict is impossible, and it's something that you shouldn't ever think is attainable. You're always going to have conflict, and it's something you're going to deal with every day as a leader, and it does get exhausting, and you're just like, really, this person again, the same person who likes to complain every day about how bad it is and all of that stuff, and they think that you should fix every little gripe that they have. You're always going to have it. You're always going to deal with it. And the best way to deal with it is ask them, tell me why you feel that way. Can you let me know a little bit more about that? Think about when you're a nurse and you're trying to ask a patient, about something that they're not really doing. Like when they talk about, maybe they're not taking care of their diabetes well. And you say, tell me why that's so hard for you. Tell me what's hard about this for you. And a lot of that it's the nursing process. It's very similar. Many of us became nurses. We're good communicators typically. And this type of conflict that you're dealing with as a leader is very similar to the type of conflict you can deal with a patient. And so the best thing you can do is manage it productively. And it's about behavior and not about people. So if you think about one of the best things that I ever learned, my hospital actually does this Franklin Covey series of leadership classes. And some of them are kind of cheesy, and there's a lot of role playing and things like that. But some of them, there's a few takeaways sometimes that are very helpful. And there was a role play one time, and one there was about, it was called Crucial Conversations was the name of the lecture series. And it was talking about how to deal with talking to somebody, having these conversations that are so difficult. And so, like when you talk about somebody when they're, like I have a lot of my day shift nurses that intimidate my night shift nurses. So my night shift nurses will be like, I don't want to give a report to that nurse. She's so scary, and she picks up everything I do. And so because we want to facilitate an environment of learning, and we are trying to resolve bullying in our unit, we're often bringing these nurses that are intimidating into the office and saying, do you understand how your behavior, try to put yourself back when you were a new nurse and think about that behavior. If somebody did that to you, can you think of somebody that did do that to you? And very often somebody did do that to them, and they think that it's okay to do that to the younger nurse. And we'll talk about how would that make you feel? Now, would that make you want to ask questions? And then that moves us on to your behavior is jeopardizing patient safety because somebody doesn't feel like they can ask questions, or that they can interject when they're getting report and clarify things because they're too intimidated by you. So it's always good to take that behavior and say, hey, when you say something like this, do you understand how that shuts down communication and that impacts your ability to exchange information nurse to nurse to make sure you're doing what's best for your patient? Now, quite often these are excellent high standard nurses, and they would never, ever want to jeopardize patient safety. And so when you make it about that and you explain to them how their behavior is shutting down that communication, quite often they're more receptive to it. And you can say, it's not about you particular, it's just that behavior that you need to change. And that's hard to explain to people. And people, when you bring them into the office and you start to want to talk to them about these things, they're very defensive, and they say, oh, I didn't do any of that. I would never do any of that. And I'm like, well, this is maybe the way you were meaning it, and the way it was interpreted was misinterpreted. And so maybe this is a way that you can, that you're clear next time. How do you change that? In the same situation, you want to take your young nurse and say to her, hey, how can you stand up for yourself? How can you say, hey, right now, this is not a good conversation that we're having right now, and I feel like we're impeding communication. And to get your young nurses to have that confidence to be able to say, hey, this is what's best for my patient right now, and this is how I'm going to establish myself as a good nurse, and how I'm going to communicate, and how I can change the focus and direction of this conversation. So that is my nurse to nurse. Surprisingly, in the last couple years, the nurses in my unit have gone to leadership. We've been extremely short-staffed and unable to, I think the nursing shortage is starting again, and we're having a lot of difficulty getting experienced labor and delivery nurses. And the hospital that I work in takes very high-risk patients. The majority of our patients are in their late 30s to early 40s, so they have all the comorbidities that go along with that and pregnancy. And getting experienced nurses is key. And then we're also doing 600 deliveries a month. And so to get, that's a lot of staff, and, people leave. But there was a letter written by the staff to the hospital leadership, the CEO, CNO, that there were unsafe situations going on in our hospital due to our lack of staff. And a few people left. This letter was sent to them. It was signed by probably 60% of the nurses on our unit. And the hospital took it very, very seriously. They talked about a culture of bullying, which I've talked to Dr. Guerin about this before, the bullying by the physicians, which leads to bullying amongst the nurses. And there's a lot of literature on that, about that. What do you call it, Dr. Guerin? It's like the horizontal, violence, and then the bullying that comes from above. But then,
yeah, that's a oppressed group syndrome. And we actually talked about it in this class, but hardly anybody came to the that webinar. And I do put a week on that too. So hopefully they have read some of the things.
Yeah. And I think it was very much happening in this unit, very much so. And I actually, when I became a charge nurse, the first, once a month we have what we call charge nurse day. And so we have meetings all day about the unit and what we need to fix and things like that. And our physician leader, chair of our department, came to the first meeting that I actually happened to be in. And I said, I left here, 5 years ago, and I came back and nothing's changed. You guys have grown in no way, shape, or form. The physicians are as out of control as ever. They're ridiculous, and people are giving them what they want, and that's not okay. And so they've been taught, and even the young ones that were nice to begin with have learned that if I scream and yell, I get what I want. And that's something that we've created. And so what the hospital did is they brought in this company called Life Wings, and it's crew training. And a lot of hospitals are doing this right now, where they use like the airline industry safety model, because they're like the safest industry, to facilitate communication in hospitals. And so the hospital, I can't even imagine how much money of this must have cost, millions of dollars probably, to put all the physicians and all of the staff in 3 units, the labor and delivery, the NICU, and the mother-baby unit, and then all of the physicians that go in those units through all of this training, so that they can learn to manage conflict better and communicate better. And there's some tools that we created for communication, handoff. We also had a few Never 28 events that contributed to this happening. And I think that it's helped. One of the biggest things that they've done is, it's been about a year since they put this into process, is we have a employee assistance program where we have a psychologist that you are able to get free sessions with. It's one of the perks of working at the hospital. And you can get 10 sessions per year. And if they decide that you have something wrong, then you can have another 10 sessions. So 20 sessions in a year, which is pretty good. And so now what they've done is, people who continue to have behavioral problems, they're forcing them to have mandatory sessions with a psychologist. And this is nurses and physicians alike. So if the physician is getting too many reports about inappropriate behavior, they're mandated to go to this psychologist and talk to them about their issues. And believe me, I've seen huge change from some of these physicians, because they know they can't get away with it anymore. And they realize that their behavior, okay, it's their behavior that is not working. And so I think that I think that I've never seen that before where the physicians are held accountable. Usually they just try to make the staff do everything that they want because they don't have a lot of control over the physicians.
I have a question about that. So those are your physicians that are hired through the hospital, but what about, do you guys have any outside physicians that are contracted that they can't require them to go through that mandatory training?
We have no hired physicians. So all of our physicians are in private practice and have privileges at our hospital. And so they made a condition of their privileges. So they said, if you do not go to these classes and you do not do what we say, then you will lose your privileges at this hospital.
That is a good idea.
Yes, and it is working, but you need a physician leader who is willing to hold them accountable. And so a lot of times when you work in a hospital like mine, which is a private community hospital, they want to bend over backwards to make their physicians happy because the physicians are bringing the money, right? Well, in this situation, they're kind of viewing it as these physicians are threatening our standing in the community. Our hospital in our community is always considered the best in our area. And the hospital realized, you know what, this is starting to threaten our reputation in the community. And so we need to fix this. And really, it's so funny because there's about 40 physicians, but really 4 of them cause all the problems. So it's kind of funny, but they happen to be the busiest ones also. And, you know, there's a whole dynamic that goes in their work-life balance too. You know, they're stressed, they work too much, they have family, you know, demands and all of that stuff. And there became an us against them mentality in our hospital, and we had to fix that.
It's funny that you say that because I feel that when physicians stop caring about their patients and stop caring about their colleagues, that's when I usually sit down with them and tell them, it's time for you to take a vacation. You need to take a vacation and just recharge your battery. But that is completely true. I think that's really great that your organization was advocating for the patient safety and your nurses and made it mandatory for them to attend those EAP courses.
Yeah, it is really, I can't imagine, it must have cost a lot of money. And there was a lot of complaining from the physicians that they had to do this. In addition to that, right now, besides getting all those patients delivered per month, we are implementing Epic, which will go live at the end of this month, and remodeling our entire unit. And so there's also, you know, a huge amount of stress going on with that too, because there's space issues in my hospital. We're not big enough for the demands that our community is making on us. So personalities, this is huge. So the doctor that I fight with the most is a big man. He likes to yell. He likes to use all of his power and to lord it over you and, you know, all of that stuff. And I finally, I had it one day with him. He was yelling at me about something one of my nurses had done. And I said, you know what, you're not my boss and you're not my dad and you can't talk to me like this. So you need to come in this room here and we're going to talk about this like adults. You need to stop this, you know. And whether he was right or wrong in that moment, maybe 50% of what he was saying I thought he was right about, but the way he was communicating it to me, we were not communicating in any way, shape, or form. And so we went into another room. I told him that his behavior was inappropriate. I told him I acknowledged what he was saying was a valid complaint. I said, yeah, I agree with you. I think that she should have called you regarding this situation with a patient. And again, I have a young nurse. She's a year off orientation. She didn't call him about some blood pressures, whatever. But then he was also playing games, not letting us give medicines to lower her blood pressure or give the magnesium medicine that we normally use for high blood pressures. He was wanting the patient to have an epidural to lower blood pressure, and the patient didn't want one. So she was a Hispanic patient. She had had 3 other babies with no epidural. She wanted to do that again, and that was her choice. And he was yelling at the nurse and intimidating her and telling her she should force the patient to get an epidural, which is so inappropriate in so many ways. So he's basically complaining to us about this high blood pressure, but not letting us do anything about it, but wanting the epidural, because guess what that does? That lets him have more control about how long he has to stay at the hospital. So his underlying thing is he wants to go to bed, okay? But he has valid things he's saying about the patient's blood pressure, although he's not treating it appropriately. But regardless of what the argument was about, it was inappropriate, and the way he was speaking to me was inappropriate. We talked about it. He moved on. I sent an email to our physician leader about his inappropriate behavior. This what happened about 1.5 years ago. This man is on his last and final warning, where he's going to have a peer review about his behavior. And if they don't see any improvement, they've put him on like a probationary period. And this is a physician who's practiced at our hospital for 25 years. So to take this man's privileges away would be a huge deal. And he doesn't practice anywhere else. He only practices where we work, and he's only practiced there for 25 years. So to take away his privileges would be massive. And he does not have enough self-awareness to realize that he is jeopardizing his practice. And it's unbelievable to me that this man cannot humble himself and see what he needs to do to change, you know? And I would say, when you're dealing with these conflict things, 90% of the time you can go, hey, we're not communicating here, and I feel this way and you feel this way, and this is our main goal. So we can agree that this is our common goal. This is what we both want, okay? But how we're getting there, we're not communicating well for us to both get there. And so how do we walk this road together where we get there? And I'd say 90% of the time you have a conversation like this with the people that are having the conflict, and you both walk away from it better. And you say, oh, I'm so glad I had that conversation with that person. Now we both are doing better for our patients. We're communicating better, and it's made our relationship. I have more respect for them, and they have more respect for me, and we're going to move on with this. And we had some growth. But 10% of the time you have these people who they just have an inability to look inward and say, you know what, this is what I own, and this is what I can fix. And there's the game playing, and there's the, withholding of information, and there's the backstabbing behavior, and there's all of that stuff. And when you're dealing with this stuff as a leader, these things are very hard to discipline people about. So if you think about your staff and you say, well, I heard you talked about so-and-so and about so-and-so, and you said this is so-and-so. Well, those are all hearsay things. You can't say, hey, on this date, I heard this and this. You can't write people up about that. So say this person's inappropriate and you want to manage this person out of your unit because they're just toxic. They're a poison, and they're, causing when I managed a smaller unit, this was really a big deal because it was so many small people in a very small space, and they had a lot of interaction with each other. Right now, my nurses are so busy that they don't get to have a lot of interaction with each other or to be able to fight. But most of the fighting happens on shift change. But the person who's a manager, if you can say, have you had one of these situations before where it's like somebody's behavior is not necessarily something you can call out specifically, but their behavior is really inappropriate. The psychologist that we use, Dr. Bill is his name, he calls that bullying light. Okay, so it's like eye rolling, withholding information, making somebody look stupid, and it's not something that you can put your finger on or that you can directly see, but that inappropriate behavior, that poison toxic person, and those are really hard people to hold accountable and get them to own their information, own their behavior.
Yes, there's different types of bullying, and what I see mostly, as far as physicians, when I've actually had problems or they've been confrontational with my nurses, day shift, I don't know why. I think maybe because they know there's more of a leadership presence there. I feel like it doesn't happen as much. And my night shift is where I can see it occurring more often. And I think it's because there's that lack of leadership. A lot of times the communication is over the phone, so they are not talking to that person face to face. In my environment, it's over the phone, so I feel like they have more courage to be a little bit disrespectful and condescending versus when they're in front of somebody and they're talking to somebody in person. So a lot of times, like you said, they have valid reasons on why they're upset. Maybe possibly could have caused harm to the patient. So a lot of times they do have a valid concern, but the way that they take that moment and instead of taking the time to give that education to the nurse and promote a safe environment for the patient, they do it in a demeaning way. Of course, the nurses are very upset. They're hurt. Then they're fearful to call again when they're taking care of that physician's patients. So that causes, like you said, a safety concern. But they know, because it's the following day, as soon as I find out, as soon as I come in, I follow up. I can remember one incident. The nurse was upset, and she had told me in the morning when I got there in the morning. So I have a lot of our physicians' cell phones, like I'm sure most of the leaders do, and I text them, hey, I need you to call me back at my extension. And the first thing he texts me back is, am I in trouble?
Yeah.
And I said, call me back. We just need to discuss this patient. So he called me back, and he did have a valid concern why he was upset. So the next question I asked him, I said, doctor, I said, I need to know, did you yell at my nurse? And he says, I didn't yell, but I was very firm.
Yeah.
And I said, okay. I said, well, this is how it was perceived, and this is why I don't want you to do those. So he apologized, and I actually had him come and apologize to our nurse, and he's been good since then. But I do feel like they have more courage when they're not talking to that person in the moment, and it's over the phone. I don't know what it is about the night shift and the telephone communication, but I feel like they do have a little bit more courage to be disrespectful or, to be loud.
I think maybe it's different in labor and delivery because the physician usually is coming into the hospital at some point in the night. So I feel like it's funny because we have an opposite issue. We have more issues on our day shift, but I think our charge nurses are burnt out on our day shift. And so there's a lack of leadership from them because they're burnt out. And that's a whole nother topic about burnout and things like that, which I'm sure Dr. Guerin has talked to you guys about. But yes, I do feel like, and think about, sometimes I'll come home and my mom lives with me and she's like my best friend, and I'll tell her about something dealing with at work. And she's like, your job is so hard. And it's so funny because when we're doing it every day, it's just our job. We don't think of it as hard, but you think about what we deal with, and we're not dealing with somebody, misbehaving at the grocery store, we're dealing with people's lives. And so their behavior, can definitely affect somebody's life, and you think about it's a huge weight and something so important. And so it's something that we always have to fix. But I love that you gave an example where you have a physician, you tell them this behavior is not okay, and he says, oh, I'm sorry, I shouldn't have done that. I agree, it was inappropriate. And he fixes it and he moves on. And I love that 90% of the time you go head on with these issues, you have a good conversation, you talk about behavior, you talk about the end goal, and you move on and you grow from that. And I definitely, there's an art to doing that for sure. Okay. Identity-based conflict. I don't see this a lot in the unit that I'm in, as far as like race or religion or anything like that. What I do see is my older nurses and my younger nurses. And I'm sure we hear a lot of talk about millennials, okay, and things like that. And the millennial nurses, and they don't care. And I don't have that experience. I don't know if my millennials, because they're nurses, are exceptional to me, or I just love young people and their passion and their energy and all that stuff. But I love them and I think they're great. But our older nurses on the day shift, they love to talk about their millennials and their behavior and how ridiculous and how selfish they are and things like that. So that identity-based conflict, there was another presentation that was put on by my hospital talking about leadership across generations. And there's some articles on that. And I think Dr. Guerin gives you one article about that. And it talks, they had this slide deck, and it talked about the intrinsic built-in thoughts about each generation. So you have like the silent generation and the baby boomers, and then you have like my Gen X generation, which I belong to, and then you have our millennials. And you talk about how they all were raised and what was going on while they were growing up and what kind of intrinsic things that they have in them and their values and thoughts. And I do think that as leaders and managers, the way nursing is right now, you have some really a lot older nurses than probably should be working because of things that happen in the economy or because they just want to work longer. And the baby boomer is such a big generation. So you have that. And then you have this millennials who are another great big generation, and they're just coming in. And I do think there's definitely issues. And tell me, I don't know if you guys see this in your units also, but you can see that their goals and values are different. And sometimes they can have trouble, even though they both want the same thing, communicating that. Have you guys had any issues with that?
Go ahead, Amanda.
Oh. Not particularly that I find. Like I said, we have, the older generation and the millennials, but I feel like at least the millennials in our nursing are very mature and focused, and I feel like they are a lot more vocal, and they aren't quite as afraid to like get in there, call the doctors, do what they need to do, ask questions, which is really important, versus like some of the like older nurses that now have to come to our floor and trying to feel it out. And I feel like they tend to be a little bit more withdrawn from the environment. So I don't particularly feel that way, but I'm also kind of like in between the Gen X and millennial age. So it's hard for me to really critique.
And Dr. You guys talk about this in class?
We have, and I actually, in my nursing 505A, it was kind of something that I focused my paper on, because what I've noticed is that it's really going to be a challenge to retain millennial nurses. So not to say that, I think I agree with you. I think they have a lot of energy, and there's a lot of good things that they can bring to the table. But I definitely feel also that it is going to be a little bit more of a challenge, because just the way that they've been raised, and the loyalty factor is not the same as some of the older nurses. And because of that, it's really embracing them and figuring out, how they tick and what motivates them and how to get them engaged. But my department, I have 105 staff that I oversee, and I want to say the majority of them are millennials. And I can say that the very, very young ones, I have some that are 19 years old, fresh out of high school, monitor tech, unit clerk, CNAs, and they're so motivated and driven, and they have goals, and they have like 3 more classes to start their nursing program. So there's a lot of energy there, and I appreciate that so much. And then I have a couple older nurses, but I don't have any baby boomers. I have Generation X, the X gens, and then I have my millennials, and then I have that next generation that are barely old enough to get a job. So those are the 3 generations that I'm having to manage right now.
Okay, that's interesting. I always say my view on millennials is skewed because my millennial nurses, and so yes, definitely, I find that meaning for them in their work, and a lot of positive feedback goes a very long way with them.
Yes, it does. Constant, and they want it immediately, immediately.
Yes, like we'll have an emergency, and like bleeding is probably the biggest emergency we typically have in labor and delivery. And I'll be like, you put that 16 gauge in like a boss, and I loved how you took initiative, asking the anesthesiologist, what does he want with labs and things like that. And I like to give that immediately to them. I also find that anytime, like when a new one comes, and I have a group that like to, go and have fun when they're off work together, and I can get one of them to be added to the group that likes to go out and do things together, because they're not very cliquey. They'll add somebody to the group very easily. They get meaning out of that. And when we do hard things at work, which we do often, and they do it together, it's huge for them. And I think that that's a huge thing for them. I did have one story that I like to share each year when I do this talk that I thought was extremely interesting. I had 2 nurses who were in their 60s, and this was when I managed my pre-op area. And then I had one nurse who was a millennial. She was, her dad was a benefactor of the hospital, and I was kind of forced to hire her into the pre-op area. And
there you go.
she was a new grad nurse. So I thought, oh, this might be difficult. So she came in and she learned to be a pre-op nurse, and she actually clicked on it very quickly. And the patients loved her. And if you think about a pre-op nurse spends an hour and a half with a patient, and then they go to surgery, and then they don't see them ever again. And so for a nurse to make an impact on a patient that quickly is very impressive. And this nurse would do this frequently. I would get notes, letters from patients. I really loved this nurse so much in my pre-op. She made me feel so relaxed, and we laughed, and we had such a good time in the pre-op that when I went to surgery, I felt so safe and calm. And I got this type of letter over and over again. And I would praise her over this, you know, and I mean, how amazing is that to make that big of an impact on a patient? Well, the older nurses who would not, they come in, they do their job. Yeah, they're excellent at IVs. They pre-op their patient 30 minutes. You know, everything was done to a T and expertly done, and nothing was missed, and it was perfect. And they were awesome too, you know, but in a different way. Their patients, you know, were competently taken care of. But maybe the patient, you know, even though they're like, oh, that was a good nurse, she took good care of me, you know, there was no, like, they move on to surgery, and no thought again was given to it. Well, the nurse that was young, she was very tall, and in the pre-op, we had to wear our OR scrubs, okay? And I want to say she was like 5'10", 5'11". So her OR scrubs would high water on her legs. And so her thought for that was, oh, I'll wear crazy socks every day because I think it's fun, okay? So she would wear crazy socks with her high water scrubs every day, and it actually was quite cute. And she would, because we would have to get to work at 5 a.m, she did this thing with her hair where she would twist her hair up in these little twists with clips, you know, because it was fast in the morning. And it was very cute, and it wasn't inappropriate, and it was fine with our dress code and everything like that. The older nurses couldn't stand that she was getting that much attention, and they felt like the way she was dressing was unprofessional. And they took this so far, they took it to HR. It was something I had to deal with in multiple meetings. They bullied this nurse so bad over this, and I could not figure out why. Like, this is such silly stuff. Her socks, are you serious? You know? And it was a very hard to manage thing, and something that I dealt with for a long time. And actually the older nurses kind of got the other ones to kind of gang up on her, and it was very hard on her, and she was crying in my office a lot, and she was doing nothing wrong, you know? And I would ask, they say she's unprofessional and she behaves inappropriately. So I would ask the OR nurses, because the OR nurses are getting her work. Basically, they're getting what she has done to the patient and taking the patient to surgery. And if she wasn't doing her work, you know, and she's unprofessional, I want to know about it, you know. So I'd ask the OR nurses, does she do anything wrong? Are your patients not pre-oped correctly? Is she missing anything? Is there a safety issue? And unanimously, not a one. So I ultimately had to chalk this up to a generational differences. And those nurses that were older, they got quite a bit of trouble for the HR. They went above me, and they went to HR, and HR flipped back on them and said, hey, what you're doing is bullying. And it was a hard situation in my unit at that time, and a hard lesson for them to learn. Somebody have a comment?
No, it makes sense. I've heard of that. I don't see a lot of it on my department. I think maybe because they're closer in age.
Uh-huh.
But I really only have 2 older nurses that are older than 50. Everybody else is younger than that. And I don't know if maybe that's what makes it a more cohesive department, because I don't have so many generational differences. But I do have a young team, a very young team.
My hospital has been there a long time, and it's quite often quite common for us to have nurses that have been there for 30 years. My day shift nurses can be a little hard on my night shift nurses during the report off, which I've talked about already. And that's something. In fact, there's one nurse there that works in the postpartum unit. I was born in that hospital, and I'm 44 years old, and she worked there when I was born there. We joke that she could have been my mom's nurse. So it's definitely there are a lot of older nurses, and there is issues. And most of the time when you tell them, you know, that's inappropriate, they're like, oh, I'm so sorry. And they stop, you know, because they're very, the baby boomer generation, they want the rules followed, if you know what I mean. Okay, on to the next thing. We talked about this at length already. And yeah, I think we talked about that too. I really like this format for the resolution process, because if you think about all conflict, it starts with a disagreement, okay, the antagonism and everything, emotions are high. And then there's a resonance where we can come together and say, hey, this is what we both want. This is what we need to do. Okay, how can we move on from this? And the invention and then the action. And that's being done very beautifully right now with the Life Wings thing that we have going on in our hospital. And I do think that will be successful. So this is a good, when you're having a conflict, think about it this way. And, it's so hard to take all your tools when you're having these conflicts and people are being so awful, to take all your tools and say, let me bring my tools back and think about what kind of tools do I have in my toolkit to deal with this conflict right now, and how can we make this better? So I think that's the hardest thing. Keep a cool head, not get pissed yourself, and use your tools, when you're dealing with these situations, because it is hard to not get, like yourself, you get mad. I mean, I've been told myself that I can be extremely direct. I'm not a yeller, but I can be very direct, and that can be considered bullying behavior. And so I've had to look at myself and say, how could I have done this differently where I was not perceived that way? Because I'm just I don't know, I'm a direct person. Blame. I mean, I think we've talked about this quite a bit already. You're so stupid and you're so mean, and it's just, it gets in those inappropriate words that we want to diffuse and get out of the conversation as quickly as we can, and stop that part, because it's not effective. It's not helpful. It doesn't do anything productive in the conversation. And it's something that you need to just be like, hey, let's stop this and let's get clear about what our goals are here. And using that word, I think when you have nurses and physicians and nurse leaders and goals is a good word to use, because that's a very used word in our profession, and we say, what's our goal here? What's our end game? What are we trying to get to? And that's something you need to diffusing something is probably the biggest thing we need to do. And I think the best way to diffuse things is to be very real and say very clearly, we're having a problem and we need to fix it. And how are we going to fix it all together? And that I find is have you guys ever had a conversation where you regretted it? I think almost always you're like, oh, thank God I did that. And I feel so much better, and everybody feels better, and we're all going to move on.
I've had conversations or actions, things that come out, and then as soon as you say it, you're like, I should have said that differently. It just didn't come out the way you wanted it to come out.
Yes. I had these, I had something blow up in my face, and I like this story too, because this is the exact way you're not supposed to do something. So I had two employees, and they were in my pre-admission screening. They were like clerical people, and they would collect all the data, medical clearances, all that stuff for patients to go to surgery. So cardiac clearance, pulmonary clearance, all those things. And they make all the phone calls to get all those things on the chart. And then once we had all those things on the chart, then anesthesia would review them and deem the patient safe to go to surgery. Because all the surgery in the Orthopedic Institute, almost 99% of it was elective. It was used to, prevent pain or stop pain, or increase mobility, things like that. It wasn't something that had to be done in an emergency, very rarely. So we had a lot of time to prep these patients and have them optimized for surgery. So anyways, these two clerical people worked in the same department, and they each had their own workload. Neither one of their workload affected the other one's workload. So I don't know why they needed to fight so much, because if this one was slacking off and not doing her work, it didn't affect this one. She didn't have to pick up her slack. So I don't know why. I don't know why they needed to fight, but they would fight all the time. The one would hear the other one on the phone and say, she talks too loud. She spends too much time talking to the patients on the phone. She talks to the person at the doctor's office for too long, and they're friends and they're making lunch plans to meet for lunch and da-da-da. And I don't like that she's doing that. Well, they were of different generations. And so my idea was, I thought, you know what? I am so sick of this. I'm sick of them each coming to me and telling me what the other one is doing. I'm going to bring them both in my office, and we're going to fix this right here, right now. Oh my gosh. That blew up in my face so bad. They start going at each other, and they are out of control. And I have lost control of this situation, even though I'm pulling every tool in my toolbox and saying, okay, we need to stop, this isn't productive, and we need to figure out how we're going to move forward, and she does this and she does this, and by, we're 10 minutes in and they're both crying and it's messy and it's awful, and I'm like, this is not good right now. So I have one step out and I talk to the one, I have the other one step out, I talk to the other one. Again, blame, 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 blame. There's nothing productive in either of these people's. So finally I said, you know what? I have to get help from HR. And I think it's perfectly fine to say, you know what? I'm not productive in this situation. This is not helping me and I need help. And I went and I got one of our HR partners and I made a meeting for a couple days later, and we all met together, and basically the HR person said, you both work here and you need to get along and get your work done, and this is not appropriate behavior in the workplace, and you both need to stop it. And that was so helpful for me at that time, because I think that I loved both these people, and I was too much empathizing with each one of them, and not in a situation where I felt like I could be objective. And I think that getting your HR business partner in to help you deal with that conflict is a very useful thing to do, and something that adding another person that can contribute and help you, whether it's like another charge nurse, your director, your manager, your educator, your HR business partner, whoever that person is, whatever you can do to help facilitate that. And here on this slide, we talk about facilitators and each party's high emotions and the projection going on, and how do you get rid of that part and move on? So definitely that one got away from me, and I was not an effective leader in that situation.
Well, you know what? I certainly wouldn't blame yourself too much. It's kind of like goes back to what you said about the physician not having a lot of insight. It seemed to me that the people that were always the hardest to deal with were those that, it's like they do project it onto the other person and they don't have any insight, it seems, on how they're contributing to the problem. So yeah, it does sometimes help if you bring in another party, because you're tearing your hair out. The one I think I talked to your class about, Trina, was when I had these two LVNs in my head and neck clinic that were like oil and water, and they'd each come to me and they'd just sit there and so reasonably talk about how it was all the other person's problem. Mm-hmm. One of them was Native American. It just makes me laugh now every time I think about it. So the one who was white decided that the Native American woman was making voodoo dolls of her and sticking pins into it. And she's telling me this with a straight face. I'm like, okay. And and then I talked to, the gal who was the Navajo, and very professional, absolutely, nothing like that. And I don't think I ever resolved the two of them. And neither one of them they loved that clinic. Neither one of them wanted to leave, but they just, I had to disagree. They weren't going to get along. It was the craziest thing ever.
Oh yeah. The manager who took over for me, she says they continue to not get along to this day, but they've managed to not let it affect their work, and basically just don't speak to each other. But you know what? If that's the resolution, that's the resolution. Yep. You know what I mean?
It's just, I guess, some people, and again, I do think some of it's lack of insight, and they don't want to find that, okay, well, somewhere in here you have about the, I'm not finding that, but finding that resolution and coming to, the place that you can do that. It's just, because they're so invested in their position that they can't, move on.
Yeah, they're both out here. Neither of them will come and meet together. Right. And try to move forward. And I mean, that's just somebody who's they're personally are in a situation in their life, who knows what else is contributing to this, or what in their upbringing contributed to this, that they have no self-awareness, or inability to say, how much of this do I own? And I definitely think when we're in this slide, it talks about being a facilitator and making sure that both parties feel safe. I think it's really important that when you bring like 2 employees in together, and you say, hey, this is a safe place. We're going to both say what we need to say here in a respectful way and try to move on. And I think it's really good when you start a meeting like that. And I didn't do that in this situation. Hey, we're coming to this meeting to resolve this issue here and now. It's safe right here. But if you're going to just go at each other, that's not productive. And how do we move on? And that's almost always what you're doing as a leader, is facilitating that movement, and how it's hard to remain objective when when we get really close to our coworkers in healthcare, because we go through a lot together. And I think that it's very hard to sit there and pull yourself back and say, hey, this is what I need to do at this time, because you love your staff, any good leader loves their staff.
One thing I can add to that is when I've had to call into colleagues because they have a disagreement, I absolutely agree with you. You have to let them know and set the stage for what the purpose of the meeting is and what you're going to allow at that meeting. Yes. In addition to that, I think making sure that they're the ones that are coming up with the resolution to the problem. Because if I tell them what to do, they're not going to do it. But if I tell them, okay, together in this meeting, we're going to come up with 3 ways that we're going to resolve this issue, and you guys need to identify what those are going to be, and I'm going to be checking in with you every week and seeing how your progress is going.
And that action plan, I think, is key. When you put somebody on a PIP, or we call it a PIP, it's a performance improvement plan, and you're trying to manage somebody out, putting those action items or being able to come back to those things that you established and you put in writing, and you said, this is how we decided we were going to move forward in this situation that we keep getting in over and over again, and this is how we're going to stop this behavior. Some people, they need those really clear guidelines.
There was one incident where I did have a problematic nurse assistant, and it was behavioral, and it was with multiple staff and also with patients. So once we've had a couple meetings with different nurses and her behavior with the patients, I think that's what I really focused it on was, yes, she was having problematic issues with her colleagues, but now it was directly affecting patient care. And she knew she was on one of her last warnings, and she resigned. So it was a good outcome for everybody.
Sometimes it's the best thing to do is help somebody leave, it really is. But this slide particularly talks about action items. What are we going to agree to as we leave here? Where do we start? And it talks about not upsetting the delicate balance achieved between the parties, and goals. How are we going to stop this and not keep getting back in here doing the same thing over and over again? And with our physicians right now, last night I was working, and we have one of our difficult physicians, and she, sorry, the allergies are bad today. She realized, she went home, and this is the 1 or 2 in the morning. She went home and she thought about her interaction with the nurse. And because she's one of these doctors that's on thin ice about her behavior, she called her and said, hey, I think maybe my behavior in that delivery could have been misconstrued, and I want to make sure that you don't feel that I was being, dismissive or, derogatory towards you, and I want to make sure you didn't feel that way, because I didn't mean it that way. And as I left and I was driving home from the hospital, I had some reflection and thought maybe you could have taken it that way, and I didn't want you to. And I'm like, whoa, this is huge growth on this physician's part. And I know she's like getting close to where she's going to lose her privileges if she doesn't stop it. And so I think that for them to be able to get to that point where they're like, hey, I might have been being inappropriate, and call and apologize. Wow. That was pretty impressive. Focusing. This is what we were just talking about. 2 employees, they lose sight. They're not moving. How do you bring it back in? Keep moving forward. And being fair. I think that almost when I was going through my master's program, and we had staff, nurses, and leaders alike in that master's program, the biggest takeaway I had as a leader is that you need to listen to your staff. They are telling you something, and be fair, and make sure, am I being fair in this situation? Am I being objective? Am I listening to both sides? Am I hearing both things? Being a leader, it's very rewarding, but it's also a hard job. Interests, definitely. Our doctors, their bedtime is their interest when I'm working at night, and let's figure out what are we doing and what are we fixing, and focus on the process to mediate, not on other interests. Let's see here. I think this is like the second. Yeah, that's like the second to the. Oops, I went back. How do I get back? Go back to the. I lost my last slide. Anyways, it was talking about interest-based conflicts and all of the sources of conflict, which I think we've greatly covered very thoroughly tonight and had some pretty decent conversations. Do you have any questions for me?
No, thank you for sharing your knowledge and your experience.
You too. I liked your feedback too.
Well, thank you, students, for coming. I wish more, I mean, we have it on recording, but I wish more could have come. I think Trina does a great job. I love to hear her talk about how she handles things. And the other thing is, it's always good to hear you talking about things you've learned in the program. It's like, when like accreditors and stuff look at outcomes, like I want to grab some of these and say, look at the outcomes we have with these great graduates. So yeah. It's so wonderful to have you back here. So anyway, so you got to go to work. It's been over an hour, and just thank you guys all for attending. And good night to everyone. And Trina, don't work too hard tonight.
Have a good night, Trina.
Thank you. And if anybody wants to discuss anything, you get Dr. Guerin, you could share my email if questions, comments, concerns, anything like that. I would love to hear from you guys. And thanks a lot for tuning in. And I know when you're in these programs, you're super busy, and often you do need to watch it later on. So I'm not offended that there were very few attendees. I think that they'll watch it later if they can.
Okay.
Thanks a lot, you guys. Bye-bye.
Bye. Again, have a good night.
Thank you.